All right, we're live. So welcome to this morning's discussion on the episode, the non-fat yogurt. So where would the group like to start? It's like a poker game here.
Yeah. I don't know, George is just great. Like or the actor in the depiction of this bad.
Yeah.
He's always been like my favorite characters. Yeah.
So for George, and you're pointing at the scene when he's in the physician's office.
Yeah. Okay.
So describe for someone who may not have seen the episode, describe the scene of George at his physician's appointment.
So he encounters essentially his like childhood nemesis, right? And now starts having this spasm, voluntary jerky movements. He goes in to the doctor, and the doctor ultimately, concludes that he is faking it. But then on the way out from the doctor's office, he, I think, bumps his elbow and experiences like a real spasm. And I think like any medical student can relate, now has that like hypochondriac phenomenon and thinks it's actually a real problem.
That's pretty universal.
Yeah.
All right, so he's in that physician's office, and actually the physician does discuss what he believes is going on, right? And just remind us, what is the physician's diagnosis in terms of anything that he's lent to the discussion?
He said that he said George
Yeah.
is faking it and wasting everyone's time.
Right.
Yeah, but it seems like he also had some anger issues. Like he was like so angry at his patient. Yeah.
So all right, so George is faking it and is wasting everybody's time. All right, so this puts us right into a particular chapter of the DSM called the somatic symptom and related disorder group, right? So let's start out with somatic symptom disorder, and then we could talk about the related disorders. Somatic symptom disorder is it's a condition, it's really a group of disorders in which an individual will present usually to a medical specialist with a chief complaint for which no underlying physical cause can be found. All right. So previously, this was referred to as somatoform disorder, and you actually needed a given number of symptoms from 4 different review of systems. All right. The DSM has oversimplified things as of 2013. As of the 5th revision, it is just one or more complaints. So a person comes in with a chief complaint of blank, and as a physician, you cannot find the underlying physiological cause. This may be somatic symptom disorder. By the way, it also may be something medical that you simply haven't figured out yet. So have some humility upon the first time seeing someone. All right. But nonetheless, that's where we are, at least for a shelf exam. Any questions about somatic symptom disorder in terms of that very brief and general overview?
So I guess my question is that, I mean, I understand that there are some patients who actually have some kind of pains that's unexplainable by the underlying physical conditions or medical conditions. But in this case, he was clearly faking it, right? But would you still consider that as the somatic symptom disorder?
Right.
Oh, okay.
So I'm gonna let me answer that question by just digressing a little bit and making sure that everybody around this table has a consensus about the terminology, including psychosomatic illness. Don't care what you learned up to this point. As of today, and certainly upon the completion of your psychiatry clerkship at RWJ Medical School, a psychosomatic illness is any illness for which there are both psychological and somatic components, period. Let me make it really simple, which means that it applies to every single entity or disease ever described. Right? Are we okay with that? All right. When someone comes in with a psychosomatic illness, as reflected by their chief complaint of blank, after your comprehensive workup, if as a physician, you don't believe or you can't figure out what is going on with regard to the somatic perspective, the only thing you can do is focus on the psychological perspective, the psycho part of psychosomatic. Once you determine that psychological variables are deemed central to the exacerbation or perpetuation of this disease entity, the terminology changes. Now we call it a psychogenic illness. It's a bit of a misnomer, but that's the genesis of the term psychogenic. So a psychogenic illness is any illness that is any psychosomatic illness for which you as a practitioner can't understand or haven't figured out what role the somatic physiology plays yet. Right? Make sense?
Yeah.
At this point, we have to all recognize that the next step is determining whether or not you're going to go down column A versus column B. And column A versus column B is differentiated by your assessment as to whether or not your patient is making a conscious effort to deceive you. And I want to phrase this very carefully. Is there evidence that your patient is making a conscious effort to deceive you? Because they may be, but without evidence, the answer is always no, they're not. We always give our patients the benefit of the doubt. It's only when there is evidence contrary to that baseline that we're allowed to steer to the left, if you will, and go down column B. Right? So our patients are always providing genuine information until they're not.
So in this case, we get the viewer's perspective of knowing what George's intent is. So knowing that intent, would you call that malingering? And then if you're the physician in that case, you don't know that backstory. Like, how do you? What would you call that?
Right. And that's a great perspective on this. So let's actually determine A versus B, our perspective versus the physicians, right? From our perspective, we know George is lying.
Right.
We know George is providing misinformation. And from our perspective, we have one other question, which is the question that psychiatrists always ask. What is motivating my patient? What is their gain? Gain and motivation are the same thing, right? If we have evidence, and again, I'll rephrase this, is there evidence of any external incentive that is motivating our patient's behavior? If the answer is yes, we're going to call it malingering. But in the absence of such evidence, they may be malingering. But our perspective is it's factitious disorder. That is, the incentive is internal or unconscious, right? And that's the breakdown. And that's the way we would think as a third-person viewer of the Seinfeld episode, the non-fat yogurt. On the other hand, if we are putting ourselves in the position, first person, of that clinician, of that doctor, and we don't have the evidence that George is lying to us, we must maintain a degree of unconditional positive regard for George. And that means that we're dealing with a somatic symptom or related disorder on or in column A, which includes, of course, somatic symptom disorder.
Somatic symptom of conversion, it's motor.
Correct.
Yeah.
And there's one more step to make, right? There's the cue. Just use my plan. How long have we been working together?
Almost a year now.
Okay, so I thought you shouldn't say too long, but it's exactly right, right? So here's the idea. Final question. Is George's complaint or complaints reflective of a motor or sensory deficit? If the answer is yes, we're going to call it conversion. If the answer is no, everything else falls under the rubric or the title somatic symptom disorder. So in that way, conversion disorder is but a variant of somatic symptom disorder when that somatic symptom localizes to voluntary, motor, and or sensory function.
Is conversion disorder, does that have to be triggered by trauma or
No.
some kind of,
But it can be. It just
It can be.
has to It just
Okay.
has psychogenic origin.
got it.
Right. So there's your breakdown. And that's the algorithm I would like you to work through in your head, because patients with symptoms that don't conform to the basic science years of M1 and M2 confound us. But if you apply this general but 2+ step process, it makes things a lot clearer. It really does. It really does, especially for a CL psychiatrist, because we'll often get, not to put anybody on the spot here, but we often get people providing a 60-minute assessment, coming back into this very room saying it's a very complicated patient. When you apply these steps, that convoluted patient and that presentation is very much simplified, right? So column A versus column B, are they deceiving us? Is there evidence of deception? If the answer is yes, the differential is going to be factitious, and that's the default, versus malingering. If there is no evidence, then we maintain a high clinical index of unconditional positive regard, And our differential then is somatic symptom versus conversion disorder. Now that's where we're at. Now, I heard child nemesis in prompting this whole discussion, and there you have the regression that is explaining a little bit more as to why George might be doing the things that he's doing, right? So not necessarily trauma, but there's always something psychological going on, and if not, just ask me. I'll remind you that the answer is yes, of course it is. Right? Yeah.
The physician too, because he made a referral, the nemesis. And so I wonder if that's part of the reason that they went to toward malingering.
That's a great point. That's a great point. Never thought about that. Yeah, that's right. And the comment was since Lloyd Braun made the referral, was there a conversation between Lloyd and the physician or clinician that drew the conclusion rather quickly? Or is this just Larry David's statement about the medical field and how they tend to jump to conclusions? Yeah. Anything else about George here? Any other questions about what are referred to as the somatic symptom and related disorders? So there's two other conditions I want to briefly discuss. One condition called body dysmorphic disorder was previously published in the same chapter, but as of 2013, DSM-5 was moved into a separate chapter, and rightfully so. Right? There's another one previously known as hypochondriasis, now known as illness anxiety disorder, which was also in this chapter, and as of 2013 stayed in this chapter, despite the fact that it should have been moved into another chapter, and that chapter would have been the same one where body dysmorphic disorder currently is. Right? So let's look at these as two anxiety-related disorders, and the first is one that I heard brought up before, and that's illness anxiety disorder, formerly known as hypochondriasis. Illness anxiety disorder is a preoccupation syndrome. And is a preoccupation syndrome that is primarily focused on having or acquiring a serious illness, right? It is currently published in the same chapter, so somehow it should be in the differential. With regard to what we just discussed, I would prefer you not think of it as such. I would much prefer for in your mind, you're categorizing it as an anxiety disorder in general, and one that is related to obsessive compulsive disorder. So it really should be moved into the obsessive compulsive and related disorder chapter of the DSM. It is a disorder related to OCD. Yeah, I still don't get why the APA kept it in the chapter that it's in. Because the way things are right now in this very chapter in your differential, somatic symptom related, it's an easy 2 and 2 with both of the columns. They throw this one in, it's an odd number. I'm a little bit OC and I don't like that. Move it over to the obsessive compulsive related disorder. It's a preoccupation syndrome. And for your shelf exam, you're going to be specifically looking for what the focus is, what the obsession is. And the answer is going to be having or acquiring a serious illness, and that's illness anxiety disorder. George has this, albeit in other episodes. The other condition is body dysmorphic disorder. This condition is also a preoccupation syndrome, and therefore, rightfully so, was moved into the obsessive compulsive and related disorder chapter. Preoccupations and obsessions are very similar. Matter of fact, kind of the same thing. And now, currently in 2024, this condition, body dysmorphic disorder, has been moved into that very chapter, those disorders related to OCD. Here, the preoccupation is not with having or acquiring a serious illness, but instead some imagined defect in appearance, right? And that's body dysmorphic disorder. Questions about the differential of somebody who comes in with symptoms that, as a clinician, you may not understand what is exacerbating or perpetuating the condition from a physiologic, part of the biopsychosocial perspective.
Do you have any pearls for like what students to get at that external motivation? Because I feel like that's always been my struggle with psych things is, you try to check that list, but like how do you phrase things to get that answer?
Yeah, I don't know if there's an actual list that I would use. I would certainly talk to pearls, because the external incentives tend to come out when you talk to the family, when you talk to nursing, when you talk to other members of the healthcare team. Workman's compensation papers need to be filled out, doc. Okay. He didn't tell you he abuses drugs. Actually, if you look at the database, he has 7 prescribers for the opioid.
Wow.
Right. So it's collateral information. It may not be a self-report. Yeah, and it may not be done day one, right? I mean, even in CL, we have a very brief window in meeting people and caring for people. We have to, again, have some humility. We're not going to learn everything we can about a person in the 1 hour assessment.
Yeah.
Characters other than George, what else caught your eye here?
Yeah.
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 Mhm.
Yeah. He's definitely got something going on too.
He certainly does.
Maybe,
Oh,
yeah.
okay, that means the third place. Okay.
So where I come from with this is he number one, he goes, as soon as they go into the lab, he goes straight to the woman over there and tries to get the date. And I think in his mind he's not trying to sabotage any of the testing, but I think there's definitely some kind of underlying motivation there driving that.
Even his comments to Elaine and Sherry were like, who tells him like that, right? Like, oh, you look like you gained weight. Like, that's a very unusual comment to hear amongst friends to make. I think it's point for his like social episode. And then making a bet and thinking about how he's doing for this episode, that he kind of had a gambling addiction because he was not in a bet and trying to have cheap bets by keeping
Not as much as George, who, given the episode, we can talk about a chapter of the DSM. I've said this multiple times. You can create an entire curriculum in medical school based on George Costanza. Right, you could. Kramer's next. Kramer's next in line. So again, not as fascinating as George, but he's got the silver medal here. You'll often hear the words odd and bizarre, eccentric, relating to Kramer. And when you hear, bizarre, eccentric behavior, I want you to think of the cluster A personality disorders. Right. So what are the 3 cluster A personality disorders published in the DSM-5? Paranoid. Right. And depending on the episode you choose, I think Kramer does demonstrate the signs and symptoms of the paranoid personality disorder, schizoid and schizotypal personality disorders. And all 3 do confer risk for future mental illness within the schizophrenia and psychotic disorders chapter of the DSM, with schizotypal personality having the highest risk. Matter of fact, in the DSM-5, schizotypal personality is published in the personality disorders chapter and then copied and pasted into the schizophrenia and related disorders chapter of the DSM-2. So it appears twice. Right? Same exact diagnostic criteria, but appears twice in that text. And Kramer's really all of the above. The teaching point, and not necessarily for the shelf exam, but certainly a clinical pearl, is that we would expect that because these different illnesses tend to cluster. They do have overlapping signs and symptoms. So, that's a clinical pearl. In this case, that odd eccentric behavior is evident. We see him, and similar to people with schizoid and definitely schizotypal, they have these movements that and focus on things that other people would not necessarily do. We often, in a sociologic way, would say they march to the beat of their own drum. That is Kramer. And to the extent, and this is where your observation, I think, is critical, to the extent that it causes clinically significant distress and impairment, it's called a disorder. So it is going to put us into that personality disorders chapter. Because in that lab, and what we see happen, you mentioned that you don't think he's trying to sabotage things, but the fact is that he does. That's Larry David's way of telling us that his behavior, that the identified behavior, does in fact have clinical significance, operationalized by there being some clinically significant distress or impairment. Right? Well, I want to ask you if any more discussion or questions about Kramer, because I do want, in the 5 or so minutes we have remaining, to talk about what is disordered behavior and how you should kind of take that with you into your psychiatric evaluations. But before I go there, questions or further observations about this character? We're good? All right. So I think in CL, certainly when you rotate on the AIQ as well, people in crisis, people with high acuity, whenever you meet a person, whether it's the initial interview or whether it's, well, maybe not so much follow-up, but certainly the initial interview, I really do want you to consider that whatever the patient is bringing to that table, office-based, hospital-based, doesn't matter, that they're conveying to you normal behavior, culturally sanctioned and normal behavior. And that's just a way to train your brain to have unconditional positive regard. I don't care what the chart says. I don't care the reason for the consult. I don't care what's been relayed to you by our front office staff or any prejudice that you bring into that room. Unconditional positive regard is what the patient is about to tell me is normal. When the patient provides you information in which they then are demonstrating abnormal behavior, then it's time to move off of that initial position. And when that happens in psychiatry, 100% of the time, resist all temptation to say, well, I'm just going to start at square two. I don't know what Toby is talking about because this is a waste of my time. It isn't, right? If that time spent is a way to train your brain to have unconditional positive regard, believe me, it is not a waste, right? Because there's other areas, especially in subspecialty training, in which that's going to come in incredibly handy for you, AKA your third year in psychotherapy, right? So it's just a thought exercise, and it's for you, not necessarily for the patient. It's for the patient, right? But it's for you. Once the patient provides you information that what they're thinking, what they're feeling, what they're doing is not consistent with a culturally sanctioned norm, you can use the word abnormal, right? From this point, as a clinician, you have to consider whether or not that behavior is also disordered. Okay? And this is a major point that has been made by the APA task force in revising the 4th edition of the DSM to its current edition, the DSM-5. And that is not all abnormal behavior is disordered. Abnormal behavior is only disordered when that stated behavior, when that recognized behavior results in clinically significant distress or impairment in functioning, self or others. And you have to remember that. Because once you could check that box, now it's time for you to actually get to your iPad, your iPhone, and look up the DSM, right? And when you get to that point, the next step is critical, and we're going to apply the next step when we discuss Escape from New York as soon as 12 noon, because that enters us into what is called a case formulation. How do we come up? What are the 5 or 6 steps that we want to now apply to come up with the single best diagnosis, shelf exam, or the most likely diagnosis in a clinical endeavor, right? So 3 steps to get there, and then if disordered, we're going to begin our case formulation, applying those 5 or 6 steps to get at the most likely diagnosis. You have 2 minutes left. Anything else from this particular episode, or any questions about anything we discussed this morning?
Was that really what you did?
Yeah. Oh, yeah.
Looks so
Yeah,
different.
yeah.
All right, we'll leave it here. We'll log off. We're going to log right back on to begin to discuss our follow-ups as part of our morning table rounds. Thank you.